So we continue with our ECG series on our channel, and I hope by now you've already digested part 1 and part 2. If you haven't, still I emphasize watch part 1, watch part 2 before you actually go ahead and look at the details of part 3. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. This is indeed our ECG bootcamp, and we're going to be carrying on how to interpret the ECG. If you haven't subscribed to the channel, please hit the subscribe button, hit the bell notification icon so you never miss on such amazing content every time I post. Grab a piece of paper, grab your pen, and let's go. Like I said, do not watch this video if you have not watched part 1 and part 2 of these particular videos. Otherwise, this will not make any sense whatsoever. I'm really serious. What are you still doing here? If you haven't watched part 1 and part 2, please head over there, watch part 1 and watch part 2 first before you actually go and watch this particular video. So remember that in the previous videos, we looked at the different steps. We looked at the introduction to the ECG, basically how we connect the electrodes and how they show up as leads on our 12-lead ECG. We then went on to look at the different steps that interpret in the ECG. We looked at step 1, where we look at the patient and ECG details. We looked at step 2, where we look at the determining the ECG calibration. We looked at step 3, where we look at the general impression of the ECG. We looked at step 4, where we determine the rhythm of the ECG, we determine the regularity, we determine the rate, we look at the P waves, the PR interval, the QRS complex, and they have a general interpretation of whether it's a normal rhythm or not. And then in this particular video, we're going to be looking at the QRS complex, to be specific, the axis of the QRS complex. In the subsequent videos, we'll look at bundle branch blocks as well as the RS wave progression. We'll be then towards the end of assessment of the QRS complex, and then we'll look at hypertrophy and ischemia in the subsequent videos. So remember that for someone to have a normal cardiac activity, the impulse must start off in the SA node, eventually go through the internodal tracts, reach the AV node, eventually go through the common bundle branch, then eventually go into the left and right bundle branches. Then the left branch divides into the anterior division and the posterior division, then eventually the Purkinje fibers. So if you look at the overall vector and the way this depolarization is actually going to be flowing, it flows in a leftward direction, it flows downwards, and it's going to be flowing towards the front of the body. So overall, when you look at the cardiac axis, it's just simply the direction at which this electrical impulse is spreading within the heart. So it will spread from the right atrium towards the left side of the body. It's also going to be going downwards and also in front of the body. So if you're looking at the hours of a clock, it's roughly about from 11 o'clock, if you draw a clock around the heart, from 11 o'clock roughly up until it reaches somewhere around 5 o'clock. So it means that if there's any damage to the heart or its electrical activity, it's going to be causing any changes in the flow of this current. So our cardiac axis is going to help us in analysis of certain things. It can help us to determine the location and the extent of different cardiac injuries, including ventricular hypertrophy, bundle branch blocks, vascular blocks, as well as even changes in the position of the heart, which could be in relation to mechanical shifts, things like pregnancy or even ascites. For example, remember that if you're having a current that is flowing from the SA node to the AV node and eventually the bundle branches and the Purkinje fibers, and as well as the ventricles, this impulse is supposed to be flowing from the 11 o'clock to 5 o'clock. So from the right side of the heart, flowing towards the leftwards direction, downwards, and in the front of the body. So it means that if the left side of the heart, for example, is ischemic, remember that this left side, which is ischemic, is not going to be able to conduct electrical impulse. So it means most of the impulse the overall vector will now be shifted towards the right side. So it means if there's any ischemia, it will shift the vector to the opposite side where the conduction can actually normally take place. So it means that this will cause the heart to shift its direction towards the right side, and we call this as right axis deviation. Same thing happens if the left side is ischemic. It means that, rather, if the right side is ischemic, it means that the right side can no longer conduct this impulse. It will shift the impulse to the left side. It's different in terms of the hypertrophies, because if the muscle hypertrophies, it means it has increased in size. So a muscle that has increased in size will increase in its generation of action potentials, and generally even the voltage that this muscle is going to be creating is much larger. So this will cause the axis of the heart to shift towards this direction of this heart muscle, because it will be generating a much greater voltage of electrical activity. So remember our heart right there in the center. We have our lead 1, we have our lead 2, we have our lead 3, AVF, AVR, and AVL. When it comes to the cardiac axis, two important leads you need to look at. You need to look at lead 1 and you need to look at lead AVF. And in some cases, you're going to want to look at lead 2. I'll explain which cases where you would want to look at lead 2. But remember that in our normal axis, it's starting off at the SA node in this area here, depolarizing and spreading over the atrium, then eventually reaching the AV node and depolarizing down the septum, spreading towards the ventricles like that. So the overall vector is moving in this direction. So it's moving in the leftward direction and it's moving downwards and in the front of the body. So it means that, remember that when this impulse is flowing towards an electrode, it's going to cause a positive deflection in that electrode. So it's meaning it's flowing in this quadrant over here. So it means that everything from minus 30 to about 90 degrees in this quadrant will show a positive deflection. The QRS complex will be predominantly positive because this impulse is flowing towards this direction, and it's obviously going to be giving you this positive deflection on the QRS complex, such that if the impulse shifts away from these axes into a different quadrant over there, it's going to cause different changes on our ECG. So what's our normal cardiac axis? So if we divide the heart into 4 quadrants, so if we divide it into 4 quadrants, we have this line here and this line here, dividing the heart into 4 quadrants. So you have from 0 degrees to about minus 90 degrees, you have from minus 90 to 180, then you have from 90 to 180, and you have from 0 to 90. So you have the positive numbers and you have the negative numbers. So if your electrical impulse is falling between 0 to 90, we would say that that is the normal axis, because that impulse is flowing towards this direction. So that's the normal cardiac axis. And remember that which leads do you find, or which electrodes do you find in this area? Lead 2, lead AVF, and lead 1. So it means you would expect these electrodes to be recording positive deflections. So even their QRS complexes must be facing upwards under normal circumstances. So it means if someone has a normal axis, you would expect lead 1 to be facing upwards, the QRS complex, because the wave is moving towards lead 1. And you'd also expect lead AVF to be pointing upwards because the wave is moving towards lead AVF. Then if now the impulse shifts to the 90 to about 180 degrees within this quadrant, we shift the vector from here, and the vector now shifts towards the right into this quadrant. We refer to that as right axis deviation. Like I said, if there is a bulk of the heart muscle on the right side has increased because it has hypertrophied, it means this side will be generating a greater electrical activity, and this will shift it from it being in this quadrant, it will shift towards this quadrant on the right side. We call that as right axis deviation. Alternatively, if there's some ischemia on the left side of the heart, which is somewhere in this direction, it means that this side will not be creating an electrical impulse that is going to affect the direction of the vector. So the direction of the vector will still shift to the side where there's electrical activity that is being created. So it will shift towards the right side. So it will cause right axis deviation. Now remember that if this impulse is now coming towards the right side as opposed to coming in this normal axis, it's moving now towards the right side. Take note that this now means that it's going to be moving away from lead 1, but it will be moving towards lead AVF. So remember, if it's moving away from lead 1, it would mean that the QRS complex in lead 1 will be facing downwards because the impulse has been shifted towards the right side in this quadrant and is moving away from lead 1. It's no longer moving towards lead 1. But then the impulse now will be moving much closer to lead 3, so lead 3 will cause a positive deflection in the AVF. So it's like the QRS complexes will be reaching out for each other. So we call this as right axis deviation. We see it in myocardial ischemia on the left side. We see it also in right ventricular hypertrophy. Now, if your impulse now shifts to the left side, so to this quadrant here from 0 degrees to about minus 90 degrees, we call that as left axis deviation. When it comes to left axis deviation, you can think of it as divided into 2 subtypes. You have the left axis deviation, which is physiological. It's normal. So if it's between the ranges of 0 to about minus 30, it's going to be considered as physiologic deviation. It happens in athletes. For example, you run quite a lot, your left side of your heart might hypertrophy to some extent, not to a pathological extent, but to some extent, such that it will cause this deviation of the cardiac axis because the left side will be generating a much greater electrical activity, so it will slightly shift your impulse towards this quadrant here. Now, if it shifts towards this quadrant here, it means that it's shifting away from lead AVF. So if it's shifting slightly away from lead AVF, we'd expect this lead to give you a negative deflection because the impulse is no longer in this quadrant, but is shifting away from lead AVF. So it gives you a negative deflection in AVF. Then if it's moving towards lead 1, it will give you a positive deflection in lead 1. So your QRS complex in lead 1 will be facing upwards. Your QRS complex in lead AVF will be facing downwards. We call that as left axis deviation. Of course, if these changes are only seen in lead 1 and lead AVF, we refer to that as physiologic. But if we also see changes in lead 2, then we say that it's going to be significant. So that's like significant or most possibly pathological left axis deviation. What we're going to see even some changes in lead 2, where lead 2, the wave in lead 2 is also going to be facing downwards. We call that as pathologic deviation. So it will be within the range of minus 31 to about minus 90. Then you may have in some extreme cases where the axis now is falling on the opposite side. So between minus 90 to minus 90 to 180 degrees. 180 degrees are along this axis. So it means that this is referred to as extreme axis deviation. You can also call it as an indeterminate right axis deviation. This is quite rare. It means that now your impulse is moving in the opposite direction. We can see this in individuals that are having ventricular tachycardia, those that have bifascicular blocks, where both the left and the anterior, rather the posterior, and you have blockage of these fasciculi. So remember, key point to keep in mind, if you have current flowing towards an electrode, it will cause a positive deflection. If you have current flowing away from an electrode, it causes a negative deflection. I think that's like a good overview of what cardiac axis is all about. So how do we assess the cardiac axis when we're coming to this step, and particularly assessing the cardiac axis? So under normal circumstances, remember we say that the flow is going to be from 11 o'clock to 5 o'clock. So it's moving in that direction. So it's moving in that direction. So it means that it's going to be flowing towards lead 1. It's going to be flowing towards lead AVF. So it means the QRS complex in lead 1 will be facing upwards. The QRS complex in lead AVF will be facing upwards. We call that as a normal cardiac axis. Then in terms of left axis deviation, remember it has shifted slightly upwards and to the left side, so it's within this quadrant here. It has shifted away from lead AVF, so it means if this impulse has shifted away from lead AVF, it means that AVF is going to show you a negative deflection, but it's shifting towards lead 1, and lead 1 will show you a positive deflection. So if you actually look at these QRS complexes, it's like as if they are leaving each other, they are facing opposite directions. So they're leaving each other. Remember this. This is also only considered as significant if lead 2 is also showing you a negative deflection. So lead 2 must look something like lead AVF, and then lead 1 will be facing upwards, and we say that that is left axis deviation and is quite significant, most likely pathological left axis deviation. Then what are some of the causes of left axis deviation? It's normal in older people and obese people. They may have the physiologic left axis deviation. We can see it in mechanical shifts. In pregnancy, this is also another physiologic type. So remember, the heart, instead of it being more in a slanted or oblique manner, it's now going to become more or less like horizontal because it's being lifted up. It's being pushed up by the enlarging uterus, and this is going to be pushing on the diaphragm. So this makes the heart in a horizontal plane, and this can actually shift the axis of the heart towards the left side. We also see it in conditions like emphysema, in left ventricular hypertrophy, because this side of the heart is enlarging and it's creating a much greater electrical activity, so the overall vector is shifted towards the left side. We can see it in left anterior vascular blocks, in inferior wall MIs, ventricular tachycardias, left bundle branch blocks, and even in a horizontal heart. And in terms of right axis deviation, the opposite is happening. So here, the axis is being shifted towards the right side. So it's going to be moving away from lead 1. So if the impulse is moving away from lead 1, we expect our deflection in lead 1 to be negative. If it's moving towards lead AVF, from this quadrant towards lead AVF, we expect this deflection to be positive. So in right axis deviation, the electrode in lead 1 will show you a negative deflection, and those that are in lead AVF will show you a positive deflection. It's like the QRS complexes are pointing at each other. It's like they're facing each other. It's like they're reaching out each other. Right axis deviation usually is an indicative feature of right ventricular hypertrophy. It can also be giving you an indication of some pulmonary conditions that may cause strain on the right side of the heart. Things like pulmonary hypertension, things like pulmonary embolism. You can also see this in very tall individuals. Remember, sometimes as you get this extra muscle on the heart, it's generating a stronger signal on the right side, so it can cause the overall vector to shift towards the right side. So causes of right axis deviation include things like emphysema, which can put right strain on the right side of the heart, pulmonary hypertension, right ventricular hypertrophy, COPDs, which cause right ventricular strain. You also have left posterior vascular block, and even the right bundle branch block. This is very easy for you to actually note. Remember that under normal circumstances, the left side of the left bundle branch is supposed to be depolarizing and then moving this impulse towards the right side. But now this right side cannot conduct impulse. So you find out that the left side will depolarize and then eventually realize that the right side has not depolarized. So there'll be a current that will shift from the left side going towards the right side, because that right bundle branch has been blocked and is no longer receiving the impulse. So there'll be this other vector that will be created to push this impulse towards the right side, which is not depolarizing. So this will shift the cardiac vector, the overall vector, towards the right side. We also see it with ventricular tachycardia. We see it also with a vertical heart. So one mnemonic that I want you to keep in mind is all good thumbs up, meaning that if its normal cardiac axis, lead 1 will be facing upwards, the QRS complex in lead 1, then the QRS complex in lead AVF will also be facing upwards. Right reaches, meaning that they're reaching out to each other, they're pointing at each other, and left leaves. So the mnemonic is all good thumbs up, right reaches, and left leaves. So you do this to remember where the QRS complexes are. If they're facing upwards, then that's normal. If they're pointing at each other, then they're reaching out for each other, that's right axis deviation. If they're pointing the opposite direction, that's left axis deviation. Right axis deviation usually seen in conditions that cause strain on the right side of the heart, seen in conditions like right ventricular hypertrophy. Left axis deviation most commonly seen in conduction abnormalities. In extreme axis deviation, this is quite uncommon, but the impulse is now moving in the opposite direction. It's moving away from lead AVF, it's moving away from lead 1, so it's moving in this quadrant in the opposite direction. So this will show both negative deflections in lead 1 and lead AVF. This is extremely rare, and in this indeterminate type of axis, it's seen in ventricular tachycardia and bivascular blocks. So here's an example. Comment on the cardiac axis below to see if you have actually learned what we've been talking about. You may pause the video at this particular moment. And here comes the answer. So as you can see, the lead 1 QRS complex is facing predominantly upwards. Lead AVF QRS complex is facing predominantly downwards. So we can establish that that's a left axis deviation. But remember, it could be pathological or physiological. We look at lead 2. Lead 2 seems to be predominantly facing downwards. So if lead 2 is facing downwards, lead AVF is facing downwards, lead 1 is facing upwards, this is a significant left axis deviation. Most commonly, or most likely, a pathological type of left axis deviation. The next example, comment on the cardiac axis. You may pause the video at this particular moment. And here comes the answer. So as you can see, we have lead 1 over there, QRS complex predominantly facing downwards. We had lead AVF here, QRS complex predominantly facing upwards. So it's like the QRS complexes are reaching out for each other. We call that as right axis deviations or right reaches. I really hope you enjoyed this video on the ECG and determination of the cardiac axis. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kasevu. Until next time, bye-bye.